Welcome to the Causes or Cures podcast, your gateway to understanding health and groundbreaking medical research in a fun and easy to understand way. With Dr. Eeks as your host, join us as we sit down with the world's leading doctors and scientists to unravel the mysteries of health. From practical tips on well-being to the latest breakthroughs in medical research, we cover it all. Don't forget to subscribe. Now, let's ignite our curiosity and together dive into today's episode.
Hello, everybody, and welcome to this episode of Causes or Cures. I'm Dr. Eeks, your host, and thanks for joining in. Hope everybody is doing swell out there. All right, so HPV, human papillomavirus, the most common sexually transmitted disease in the U.S. Most people, especially women, when you think about HPV, you think about how it is linked to causing cervical cancer. And then you might think about pap smears, right? You go to the doctor, you get a pap smear to make sure an HPV infection didn't lead to any abnormal cells or precancerous cells. And if you have an abnormal pap smear, you follow up with your doctor. And in most cases, you catch it early enough to avoid cervical cancer. I mean, the beauty of the pap smear is that it can and has saved a ton of lives. It's not comfortable, no. And it's a pain to go to the doctors and do it. Trust me, I know. I hate going to the doctors, but I do drag myself in to get pap smears. Why? Because it is one of the most cost-effective, successful screening tools we have, and it can save your life. That's what it boils down to. It can save your life, and it's easy to do. And it's also really important that if you have an abnormal pap smear, to go back to your doctor and do the whole follow-up care. I'm reading about how some women are getting the pap smear good, but then they are not following up if they have an abnormal pap smear. And that's not good. It's like ignoring a big warning sign, you know, like if you're in your car on a road trip and everything feels fine, you feel like you can drive for days, but something starts flashing and says, hey, your car is going to blow up if you don't pull over and fix the engine. You got to pull over and you got to follow up, no matter how big a pain in the butt it is. You got to follow up. So HPV and cervical cancer is on most people's radar. And you know, we most often think about women being at risk from HPV. But what we don't talk about as much is HPV and oral cancers like head and neck cancers, throat, you know, stuff on your head. And that impacts men and women, but mostly men. But anyhow, let's learn more about this stuff from someone who actually treats HPV-related throat cancer. My guest today is Dr. Andy Sikora, who is Director of Research for Head and Neck Surgery at M.D. Anderson Cancer Center in Houston. And he's going to tell us more about how HPV causes throat cancer, who it impacts the most, and any risk factors, symptoms, and signs that you might have, what a typical course of treatment looks like. And then the prognosis, meaning how well will you do if you have it, the docs diagnose it, and you treat it. Oh, and we'll talk a little bit about the HPV vaccine too. Okay, so give me a second here, gang, while we connect to Dr. Sikora. All right, everybody, we are connecting with Dr. Andrew Sikora, and thank you so much for joining the podcast. And I thought I would let you introduce yourself and kind of tell us what you do and, you know, in medicine and research and that sort of thing.
Yeah, fantastic. Thank you so much for the opportunity to join you on your podcast. I think it's great that you're getting this sort of health-related information out to people. And I love that you're, kind of doing a deep dive into some of these topics that maybe people haven't heard about, or maybe they've heard about and, were a little surprised to hear about men and HPV. So I really appreciate that. So I am a head and neck surgical oncologist and immunotherapy researcher at M.D. Anderson. It's a large cancer center in Houston, Texas. In my lab, we study ways that tumors turn off the immune system and make immunotherapy less effective or ineffective and make other types of therapy less effective as well, and how we can get under the hood and reverse those mechanisms. And then I've also, as a head and neck surgical oncologist, been interested for many years in the phenomenon of HPV-related oropharyngeal cancer, which is currently the fastest growing, or I should say, the head and neck cancer whose incidence is growing the most quickly, and is something that when I was in training back in the early 2000s, we thought was maybe a possibility, like maybe HPV might cause throat cancer, and we now know it to be the predominant cause of throat cancer today.
All right. And so I mentioned this before, we hear about HPV and cervical cancer. Women are told, get, your pap smears done, and the rate of cervical cancer has gone down because of the pap smears and people following through after the pap smears. And then there was the introduction of the vaccine. But, I mentioned at the beginning of the podcast that the most common HPV-associated cancer is HPV-related throat cancers. So I guess let's just start there. Maybe kind of when, people started to say, hey, there might be a link here, and how does it cause it? And maybe is there like an incubation period? Does anybody know how long that might be? And does it get cleared? So just, dive into the story of that.
Yeah, great question. So, head and neck, I'm going to back up just a little bit and say a few general things about head and neck cancer. It's not one of the most popular cancers. We don't have 10K races and things like that. So not everybody knows someone who's had head and neck cancer. We used to think of it as primarily a disease of middle-aged to older men, primarily associated with tobacco use, with or without alcohol use. And over the course of the past few decades, that picture has really changed as the HPV-related head and neck cancer has become more prevalent. So HPV, or the human papillomavirus, is a virus that we know is sexually transmitted. We think it may also be transmitted by different other types of intimate contact that are not, strictly sexually transmitted, but still involve people getting very close to each other. Things like, deep kissing, oral sex, so on and so forth. And people are sometimes surprised to think about the idea that you can have a sexually transmitted disease up above your shoulders. So sometimes it takes people a little time to think about that. But at this point, we certainly know that to be true. So we imagine that most people are probably infected, at least for the first time, with HPV, sometime in their teens, their early 20s. And the cancers that are caused by HPV tend to occur decades later. So in the case of throat cancer, we're talking about cancers developing typically in people's late 40s, 50s, early 60s. So that is what we sort of imagine the incubation rate to be. However, although that data is still emerging, there may also be a role for reinfection or repeated infections over time, potentially increasing people's risk.
I remember when, you probably remember this too, when Michael Douglas spoke to the British newspaper, and he talked about, I think in 2010, he was diagnosed with throat cancer, and he said it was caused by HPV. And that was in the media for a while. And I think, people were talking about it more, and then it kind of fell out of, the media, and no one really mentioned it again, at least I haven't seen it really talked about. But can you talk a little bit about the epidemiology in terms of, who gets it, men versus women? You mentioned the age range. And also I was curious about the risk factors. And do you see, I'm asking you like 3 questions at once, so I'll stop there and let you go from there. So go ahead.
No worries at all. So in terms of who actually gets the cancer, so So unlike, for other cervical cancers, obviously cervical cancer is a disease of women. Throat cancer, it can be a disease of both women and men. It is more common in men, so it's more predominant in men. And in fact, pretty recently, within the past couple of years, something that we've been predicting for a while actually happened. The number of cases of HPV-related throat cancer in the U.S. went higher than the rate of cases of cervical cancer in the U.S. And that was pretty shocking to a lot of people. So primarily a disease of men, primarily a disease of, early to middle age. In terms of risk, the age at first, sexual contact, number of partners, things that make sense for a sexually transmitted disease to increase your risk, are certainly major factors. Something that most people don't know about themselves, but when we measure it experimentally, increases risk is, do you have HPV, sort of carried in your mouth and throat? Is the HPV virus actually there? So when you look at people and their, viral carriage, that's one of the things that kind of predicts, well, who's at higher risk of getting cancer. And again, that makes sense because we're telling you that the virus causes the cancer. So if we find the virus, that makes a lot of sense. And also things that can affect your immune system can also increase your risk. So things like immunosuppression, whether that be HIV or whether that be induced medically, for people with transplants. We believe that also affects your immune system's ability to fight off the virus and the subsequent cancer it causes, and puts you at higher risk.
And I mentioned the pap smear, and obviously that's a really vital screening test for cervical cancer. But just to kind of emphasize for the listeners, there's no screening test for this. Is that correct? Like there's no swab or anything or that you can do?
There is nothing clinically available, which is a huge frustration. So, your listenership is probably aware that the pap smear has probably saved more lives worldwide than most medical interventions we can think of that aren't a vaccine. It's really changed the natural history of cervical cancer by allowing people to get diagnosed before lesions progress to cancer or before the cancers become difficult to treat. We have nothing like that for oropharyngeal cancer. Or throat cancer. And to sort of explain, why is that? Why have we had pap smears for decades? And, here we have another HPV-related cancer, and we don't have really any good screening tools yet. And some of that comes down to the anatomy. So when we talk about HPV-related throat cancer, the technical term for it is oropharyngeal cancer. What is your oropharynx? Your oropharynx is what you see basically when the doctor says, say ah, and you stick your tongue out and you look back and you see your tonsils and you see sort of the back of your tongue. That's your oropharynx. So it's the base of tongue, it's your tonsils. Those are the areas that the HPV virus likes to get into and, multiply. And that's where we tend to see these cancers. Those areas are incredibly irregular. They're ridged. They have what we call crypts, that kind of dive down deep. They're very, very different from the areas that get sampled for pap smears. And long story short, there's just no way to get a probe into there in a way that's going to get you that sample that you can then subsequently test. It's just too complicated and too large when you spread it out completely an area to sample effectively.
Well, that's unfortunate. But so I guess when somebody, comes to your office, maybe can you just walk us through how you might diagnose somebody as having throat cancer and what that would look like?
Absolutely, absolutely. So typically, so someone like myself, who's a head and neck surgeon or a head and neck surgical oncologist, we're going to see patients who are referred to us by community otolaryngologists, so ear, nose, and throat specialists, or community, general practice doctors. And interestingly enough, even though it's throat cancer, the thing that usually tips people off, I would say, in at least 3/4 of the patients I see, is they all have the same story. Men will come in, they will say, "Oh, I noticed a lump in my neck when I was shaving." So really, right now, the best screening test we have for HPV-related head and neck cancer is to tell people to go get a shave at the moment, because that's what drives most people into my office. So something about the virally induced cancers makes them cause spread. They spread to the lymph nodes of the neck relatively early, and those lymph nodes get big and kind of cystic. They're kind of like they often are kind of like bubbles full of fluid, and people notice that. They go to the doctor, and now people are more aware, and typically they'll come to us. We will take a look and see if we can see, well, where is that neck mass coming from? Where did it start? What we call the primary tumor. So we'll examine them both by, typical oral exam like any doctor would do. We also have a little fiber optic scope that we put down people's nose and look panoramically around their throat, and that lets us look at the base of tongue and their tonsils directly. Sometimes we can identify it. Sometimes we have to use tools like CAT scans and PET scans to go chasing after where that neck metastasis is coming from. So that's sort of what a workup looks like for us. Once we find where we think the tumor is coming from, we sample it, and that can be sampling the lymph node itself, or that can be sampling the primary tumor if we're able to find it, and then we send it off for testing to determine if it's HPV related or not, and then that helps us understand what's the patient's prognosis and how are we going to approach the treatment.
So it goes to kind of like the path lab or the laboratory, and then they check to say, oh, it's HPV related. So if the report comes back, it says, okay, it's HPV related, what would you do next in terms of treatment approach?
Yeah, so that report comes back. First thing we do is talk to the patient and their family about, what that means. Usually, I would say people are getting more educated about the possibility of HPV-related throat cancer, but it's still kind of a new idea to a lot of people. So we have to kind of go through all the things that we just talked about in terms of the epidemiology. And one of the things I like to, emphasize to people is it's probably the only time in your life anyone's going to tell you, good news, you have a sexually transmitted disease. And what I mean by that is that the HPV-related cancers are more treatable, whether they're treated surgically or whether they're treated with radiation. They are generally more responsive to therapy than the, kind of old school smoking-related tumors. So that's actually, good news for most patients. Now, how do we treat them? So they're at most institutions for years. We have treated them primarily with radiotherapy, often with chemotherapy. So the combination of the two, chemoradiotherapy, has fantastic results at most centers. For all comers, 75 to 80%, have complete remission of the disease. It goes away. And for years, that was really how we treated these tumors, because prior to the advent of robot-assisted surgery, if I wanted to do surgery for most oropharyngeal tumors, the way we would do it is we would split the jaw open and basically open it up like a book and reach in there, grab the tumor, and put everything back together. Now, from the expression on your face, I'm thinking that does not sound appealing. It doesn't really sound appealing to very many patients. We don't do much of that anymore. But the advent of robot-assisted surgery, and since we're in the era of ChatGPT, I'll mention that the surgeon is still driving the surgical robot. But essentially what it does is it creates little extensible hands with little fingers, and it puts the vision of the surgeon like literally, centimeters away from the tissue. And it allows us to get around corners and get into spaces that are too tight, to really, put our normal big ham hands. And so robot-assisted surgery has changed the approach to HPV-related throat cancer in particular, because a lot of those tumors, particularly the ones that originate in the tonsil and then some of the smaller tumors that come from the base of the tongue, they're pretty amenable to robot-assisted surgery, followed by what we call a neck dissection, which is removing those lymph nodes that the tumor can spread to. So that's done from the outside through a conventional incision. And after patients are treated with that surgical approach, they may not require further treatment, or they may require radiation or chemotherapy. But pulling the tumor out of the patient gives us an opportunity to interrogate it pathologically and look for risk factors that help us individualize what their subsequent treatment is going to be.
And I wanted to ask, you've been like the main investigator for clinical trials designed to test immunotherapy. Do you do any of that for these types of tumors, or is it other genres of tumors?
Yeah, so immunotherapy in head and neck cancer is, I would say, equally applicable to both HPV related and HPV unrelated tumors. They both can potentially respond to different types of immunotherapy. I think there's kind of a feeling in the field that the HPV-related tumors may sometimes respond a little more directly to things like checkpoint inhibitors, which are currently the only approved immunotherapy approach for head and neck cancer. But that's, that difference is not very strong. So we think about immunotherapy as something in our toolkit for both kinds of head and neck cancer. But there are emerging immunotherapy approaches. So things like therapeutic tumor vaccines. So we've all heard of the preventative vaccines. Those are the ones we're giving, our teenagers and our children in order to prevent HPV-related cancers. But there are also vaccine approaches that are designed to treat existing tumors. And one of the things that's kind of special about HPV-related tumors is they have these viral proteins, that are actually made by the HPV. And those are potential immune targets, and those are foreign to your body. So your immune system looks for things that are not supposed to be there, and viral proteins are not supposed to be there. And that gives us a really good therapeutic target for designing therapeutic vaccines.
But in general, it sounds like the prognosis is good, or like not bad.
It is. I mean,
maybe there's another word for it between good and not bad.
No. I think it's definitely better than conventional smoking-related head and neck cancer. And anytime you're sitting in a room with a patient telling them they have cancer, it's you're not giving them great news, but it is wonderful to be able to give them the news that this is a tumor that, if untreated, would ultimately kill you, but if treated, has an outstanding chance of completely going away and not coming back. So that's the good news about this tumor. We cure many patients, and it doesn't really matter what approach we take: chemoradiotherapy, surgery. There are, the majority of patients, actually have a complete response and their tumors go away. Now, the heartbreaking thing is when you've told a patient they have the easier to treat type of tumor and it comes back. Because when these tumors come back, if they're fully treated and they come back, their behavior is not good. And just like any other recurrent cancer, they become much more resistant, much harder to treat. And we really, have to kind of pull out the big guns to try to get these patients treated.
So let's talk a little bit about the vaccine, and just for our listeners. So the first HPV vaccine was approved in 2006 for young women between the ages of 11 and 26. And then in 2011, they added boys to that list. In 2018, the recommendation expanded again to the ages between 9 and 45. And then in 2020, I read the FDA gave an accelerated approval to prevent oropharyngeal cancers, but they're still doing a trial right now. Does that sound accurate? Yeah, okay.
Yes, there will be trials going on for quite some time because, the trials are slow. Like to do any kind of vaccine trial, you're giving an intervention to many people who wouldn't get the disease in the first place, and then you have to follow them for a very long time. So the trials take forever. So a lot of what we know about the application of these vaccines, and here we're talking, of course, about the preventative vaccines that you would get from your local doctor. A lot of what we know is by extrapolation to what we've learned over the past few decades from women, because we know that men and women, there are many differences, but overall the immune system works very similarly. We respond similarly to vaccines. And we have indirect data, for example, that's really sound that shows that when boys are vaccinated, their rate of oral HPV positivity, what I told you about, where we experimentally actually look inside their throats and say, is there HPV there? That goes down. That is well known to be a risk factor for cancer. So it just kind of makes sense that vaccinating boys is going to be an efficacious way to prevent them from getting cancer and to protect their partners in the future.
And the timing of the vaccine, like HPV is a sexually transmitted disease, so it makes sense to give it before people, become sexually active. But is there some benefit to getting this vaccine anytime during your life, up to age 45, I guess, or even getting boosters? Would you think that would be an added preventative effect for something like this?
Yeah, really good question. So the number one priority is to try to get people vaccinated young, as we've mentioned in this interview a couple times, and that's still the number one priority. The best prevention is the earliest prevention. With respect to number of doses, you want to get 3 doses in for girls. I believe the recommendation for boys is still 2 or 3 doses. So, I think what the data seems to show is that once you have those numbers of doses in, that the protection is expected to be pretty long term. I'm not aware of boosters being proposed, but I'm not aware that somebody's not studying that somewhere. And this is, as you can imagine, an area where there's a lot of research going on. With respect to your other question, let's say I missed that window as, child, teenager, let's say I'm in my 20s, 30s, 40s even. Is it still worth my while to get vaccinated? And there, I would say the thinking has really changed over the past few years from, hey, go for it if you want to do it. No one's going to stop you, to, yeah, why not? That sounds like a good idea. And over time, the potential benefit of being vaccinated at older ages, has begun to emerge from the science. And that's why I think you see those recommendations changing over time. I certainly support those recommendations and think it makes sense for people of any age. If you can get yourself access to the vaccine, I don't really see a downside.
Yeah, it's interesting because it's a vaccine that kind of focuses more, like the communication around it focuses more kind of on the individual benefit versus, when people think of like the measles vaccine or, the polio vaccine, or they think of it like in terms of transmission. So I'm always interested in how, I'm saying so how we talk about these things, I think affects how different subpopulations will respond. In terms of or a recommendation is one thing. I guess a mandate would be another topic. I think we've learned that it's very hard to mandate vaccines. Education is really our best tool, and I think most people want to protect their own health. Most people want to protect the health of their children, and most people are, I think, pretty amenable
to getting vaccinated, but not all people. And, as you pointed out, you can protect yourself even if you're with people who are not vaccinated by getting vaccinated against HPV. So that's something every one of us can do on a personal level to protect our health, and something we can do for our children. But yeah, when you start, I think we've learned from the past couple of years, when you start talking about vaccine mandates, that becomes a much more difficult conversation. So I feel like my role as a health professional is to try to get the word out. These cancers exist; they are preventable. We should do what we can to prevent them.
Yeah, you're exactly right. It introduces feelings and beliefs into the conversation when you say mandate that wouldn't otherwise be there. Like if you're just having like a conversation about, how to protect, like the just risks and how to protect yourself and what you should do. It's just interesting from a psychology perspective.
It is. And I feel like a lot of people feel that they're not listened to, and that can create additional barriers to communication. I have gotten in the habit when patients, tell me they're not interested in, getting vaccinated, or they're not interested in vaccinating their children, instead of saying, well, you should, and kind of moving on to the next topic. I just ask why, what their concerns are. And depending on the individual, sometimes those concerns are just, things to talk about. And at the end of a conversation, they're going to feel more positive about vaccination. Other times, you're not going to change that. You're not going to change that particular mind, but there's still ways that you can help.
So this was all great. I think, just putting this on people's radar was kind of like my goal with the podcast. So I really appreciate you coming on. I have to ask, because everybody's talking about AI. Are you guys talking about that there at all? And curious as to where it'll take, your field and your profession?
Yeah, that is a great question. I think, it's impossible to pick up a newspaper without reading about these large language model AI systems. And obviously, we've been thinking about their application to medicine, since the moment these were reported. As of yet, the large language models don't have like little fingers and opposable thumbs. So I feel as a surgeon, I'm relatively safe little while, but once they hear about the surgical robots, it might be sort of like, oh, well, we can dispense with the middleman. But I think that these, like any other technology, we're going to see a lot of applications where it can help support decision making. It can help people take large amounts of data, and increasingly medicine requires the aggregation and sort of internalization of a lot of data, which you then have to spit out in a much simplified way to talk to your patients and even talk to other professionals, who just don't do exactly what you do. And I see these models as potentially helping with that. I think that that's going to be a while before we turn over medical decision making to them. I don't think patients are ready for that. I don't think doctors are comfortable with that. But I certainly think they're going to start creeping into medical practice in different ways. And I'm excited to see both what the benefits are, and a little bit nervous to see what the sort of case too far turns out to be. And I guess we'll know soon.
Yeah, no, I agree. It's kind of like in that it's exciting, but it's also scary. Although I will say this, just having, gone to West Point and stuff, and always, studying military history and the evolution of military weapons. Like, I feel like we already have all the stuff we need to like destroy ourselves if we're thinking about the potential negatives of AI. I'm like, I don't know if we should worry that much, because there's already enough stuff out there where, we could do some damage on each other if it's, related to technological advancements. But
yeah, in an ideal world, we would learn from those scenarios and apply them to this one, but it's not clear we've learned from those scenarios, right? That's the concern.
Yeah.
I want to mention one more thing, just because we're doing this interview this week. You may be aware one of the pioneers of HPV research actually passed away, I think, over the weekend. Harald Zerhausen, and I can send you how his name is spelled. But he is a scientist who, when nobody thought HPV could possibly cause cancer, he literally was the lone voice saying, well, I think it does. And he did exactly what scientists should do in that situation. He kept studying the problem, amassing data until finally he got to a point and his tools got to the point. The scientific tools evolved where he could provide incontrovertible proof. And so he was awarded a Nobel Prize in, I think, 2008. For the discovery of HPV as a major cause of cancer. And he passed away this weekend, but he's sort of a hero in the field, somebody who didn't take no for an answer, and because of that saved untold, hundreds of thousands of lives, if not millions.
Wow, what a contribution, and has quite the legacy. I didn't know that, so.
Yeah, he just passed away, but boy, he had a full life. So I recently read his obituary, and I was like, wow. They commented on not only like how impactful his work was, but just what a gentleman he was and how kind he was to other researchers. I'm like, oh, I don't always see that in profiles of successful scientists. That's pretty cool.
Yeah, it is actually remarkable when you hear somebody else described as kind. Because you don't, it's something you don't always hear for notable figures, but yeah.
It is an underappreciated word. It's one of those sneaky little words that can make the world a better place.
Absolutely. Well, thank you for this. And I look forward to sharing it and getting the word out and hearing what people have to say about it. Hopefully stimulate some conversations. And what's the next research project you're working on, or do you have like a publication that's going to come out soon, or?
Yeah, so one of the things my lab has become interested in is how these sort of standard of care therapies, things that sound boring to us, like radiotherapy and chemotherapy. And when I say boring, I mean just because they've been around forever. We're increasingly understanding that these have sometimes very profound and very subtle effects on the immune system. And that while we're still out there trying to develop new immunotherapies and new targets, that we haven't studied before, we've got a whole lot of really potentially very powerful immune modulating tools already described, already, safety profiles known, already in clinical practice, and we have to figure out how to sequence them and how to put them together in such a way that we can modulate the patient's immune system so that they actually respond to immune-based therapy. So that's something my lab has become really interested in, and we're trying to understand sort of how some of the, basically just trying to hack, some of these chemotherapy agents and figure out, well, how do we get them into the tumor in a way that can flip the tumor from something that ignores an immune assault to something that, is actually going to respond.
Well, that sounds cool. Sounds like it can do a lot of good. It's all like, I'm always so interested in because you just always hear somebody new, Larry, that getting diagnosed with cancer, and you're just like, oh God, it's like awful. So it'll be really interesting to see where, I don't know if I'll be alive, but to see where, the treatments evolve one day, if you can really just kind of get a handle on it, and it won't be such a big, scary word for people. You know what I mean? Like, it's just, if you hear that word, if someone tells you have that, it's like just completely life changing. Yeah.
It's something I still, I mean, there's a lot of optimism about cancer treatment. And if you look at the statistics, slowly but surely, both prevention and treatment, they get better and better and better for most cancers. But I always remind my trainees that when you're sitting there in the office with the patient, talking to them about, their cancer, this is the worst day of their life. This is generally going to be like the worst thing that's happened to them. So at least that's how they see it. And you just have to keep that at the back of your mind, and whatever you can do to, help them understand that, yeah, it's a big, scary word, and yeah, it's real danger and it's a real threat. We have tools and things that we can bring to, the treatment of our patients that we couldn't have even imagined, decades ago. And it's going to keep getting better.
All right. Well, thank you so much for your time today. And best of luck with all this. And I will get this out there and let you know when it's posted.
Thank you so much. I really appreciate the opportunity to catch up with you. And I really appreciate what you're doing to help educate the public about all these really important topics. Thank you so much.
Thank you. All right. Okay. And enjoy the rest of your day there.
You too. Have a great day.
Okay. Bye-bye.
All right. Thanks, everybody, for joining in for the HPV podcast. As always, I hope you learned something or found something interesting. Please feel free to share the episode and tell your buddies. If there's something you didn't understand, or if you have any questions, feel free to send me a message through my website, my blog, bloomingwellness.com. And I hope you consider subscribing to the podcast and or even subscribing to the newsletter. There is a link in the podcast episode description where you'll be able to keep track of, if you sign up to the newsletter, you'll be able to keep track of everybody who's coming on the podcast. And you'll also get to read some of the things I write in my blog related to public health issues. And some stuff written by guest bloggers, like my friend, Dr. Andy Karam. He just wrote a blog on the difference between strategic nukes and tactical nukes. So, a little different than HPV, classified under the Apocalyptic Health and Wellness series. But seriously, it's interesting stuff. It's timely, and it arms you with a lot of dinner trivia, most importantly. Dr. Karam also did a podcast on how you can survive a nuclear bomb. Of course, if you aren't like in the blast radius, right? So you can scroll on back through the episodes to listen to that one. All right. On that uplifting note, now it's time for the ending quote. This is from Mira Grant in Countdown. Ready? There is nothing so patient in this world or any other as a virus searching for a host. Then there's that other quote, patience is a virtue. So viruses are virtuous. They can be virtual, but virtuous. Okay, you know what? I'm going to let that go. Because no need to connect the quote game here. All right, everybody, go out there and have a good day, do good things, and, get on with it all. All right, till next time. Bye-bye.